Longboard.
Hi.
Hi, how are you doing?
I'm okay.
I'm Dr. Liz. We've already met, but I just want to come and talk to you a little bit. We're going to be admitting you upstairs
Okay.
for acute COPD exacerbation. Your chest x-ray came back negative. Your creatinine levels are a little high. This is a sign that your kidneys are being forced to work harder due to having a mild respiratory tract infection. So we'll be moving you upstairs.
Okay.
Do you have any questions?
I don't think so.
Okay.
I brought you Mrs. Longboard. She's a 64-year-old female. She has a history of seizures, hypertension, and COPD. She has 6 home medications for her seizures and her COPD. I've updated those in your MAR. She came to the ED last week because of wheezing and trouble breathing. During her physical exam today with the physician, she had worsened breathing with the movement. Her chest x-ray was negative for pneumonia. She's being admitted for her COPD exacerbation and mild respiratory tract infection, and her blood work also showed that she had increased creatinine levels.
Okay, thank you. Hi, Miss Longboard. I'm Tiffany. I'm going to be your nurse today. How are you feeling?
Just hard to breathe, but that's normal for me.
Well, for your treatment today, we're going to start you on some steroids and a bronchodilator to help with your COPD exacerbation. So right here I have your oral steroid, and then we're going to have respiratory come in and give you your breathing treatment.
Okay.
Then I'm going to check your fluids real quick, make sure everything's going at the doctor's rate. And you're, how do you feel like you're breathing right now? You're going to be on 2 liters. Does that seem okay?
I feel like I'm okay, just a lot of fluid, like you were saying the upper respiratory thing. I do feel like I have a lot of fluid, so make it hard to breathe.
All
but
right. Well, hopefully respiratory will be up in the next 5 minutes to break up some of that mucus and secretions that are in your lungs.
I think that'll make me feel better.
I'll come back and check on you in about an hour, and I'll let you know if there's any updates from the doctor.
Okay.
Thank you.
Mom, it really seems like you're starting to improve. They've been saying that you've been doing really well, and they might be letting you go home soon. How are you starting to feel? Feel okay? Like you can go home?
Well, I feel like my breathing's getting better, but I keep having this pain in my leg. I don't know what's going on. My left leg hurts, like whenever I move it.
And the back of the leg, it hurts?
Like, really all over.
Well, maybe when they come in, we should talk to them about it.
Sorry. My legs are really hairy. I haven't had time to shave.
That's okay, honey. That's okay.
Oh, it really
Hi,
hurts.
nice to meet you.
Hi.
I'm Mrs. Longboard. My name's Julie.
Hi.
I'm a resident here. How are you doing?
We were
Well-
just talking about this pain that she was having in her leg.
When did this pain start?
I don't really know. It's the past few days since I've been here. It's been really red and swollen.
I can see where it's red and swollen here. Do you take any aspirin or blood thinners at home?
No?
Nothing like that? Okay, well don't rub or massage that area right now until we get it looked at. I can talk to my supervisor and our team, and we'll check about getting you an ultrasound ordered, and we can see what's going on with your leg.
Okay.
Okay? So let me go talk to them, and we'll be back and let you know in just a little bit.
All right, thank you.
Nice to meet you.
Thanks.
Hi Bethany, do you have a minute? I have a concern.
Yeah, what's going on?
Well, my patient, Mrs. Longboard, in 54, I just wanted to check on her, and she's complaining of some pain in her leg, and there's some swelling and some redness, and I'm kind of concerned about a possible DVT.
Okay. Do you know what medication she's on right now?
She's on medications for hypertension and for her seizures, but I'm not currently seeing any antiplatelets or anticoagulants.
Okay, let me look her up here real quick.
She was just admitted from the emergency room upstairs to our floor.
Huh. The admitting doctor didn't order any prophylaxis for DVT. No blood thinners or anything. Does she have any STDs or?
Nope, there were none placed. She just came up from the ER 3 days ago, they said, but there was no STDs when I just entered the room and assessed her leg. I
Okay.
feel like that should be kind of a standard to prevent this of being bedridden.
Okay, yeah, because there's nothing here in her record that suggests why she shouldn't be on any kind of blood thinner or anything to help prevent DVTs. Because usually when a patient comes in and they're not moving a lot and have all these other things going on, they are on a blood thinner.
That's what I thought as well, so I think we should get an ultrasound as soon as we can so we can see what's going on if it's a DVT so we don't go to further complications.
That's a good idea. Okay, good. Good catch.
Thank you.
You're welcome.
Hello.
Hi.
I got the results of your ultrasound back and we do see a DVT in that left calf area. So we're gonna go ahead and get some orders started to try to resolve that, some medications and some therapies, and we'll get that taken care of for you.
So we shouldn't rub on it or massage it or anything?
No, we're not gonna wanna touch it or rubber massage because the blood clot has a potential for dislodging and it could move into your lungs or into your brain, cause a pulmonary embolism and you have more trouble breathing or a possible stroke. So we're not gonna wanna touch it or dislodge that blood clot until we can get some treatment for you, okay? So we're gonna get these orders in and we'll get you taken care of, okay? Any more questions for us right now?
I don't think so.
All right, thank you.
Hi, Julia.
We had a few concerns about a patient that we had that we wanted to bring to you as the charge nurse.
Okay.
So I had a patient up in 54 and I went and checked on her yesterday and she complained of pain in her leg and I assessed it and it was red and warm. We had an ultrasound and we saw a DVT on the ultrasound.
Okay.
So she had no STDs in place as she was here 3 days and she was on no anticoagulants. So we were wondering if there was a policy or any standing orders that should be put in place for DVT prevention.
Okay. I'm not sure if there's a policy or not, but I can look into it, and if there's not, we can work something out and try to come up with something to prevent this in the future.
Yeah, because typically at other hospitals I've been at, when a patient comes in that puts them in a high risk for developing a blood clot, there's an automatic set, like standing orders that they start Lovenox or some kind of blood thinner to
Right.
prevent it.
Right. Okay. I will talk to management and we'll look into this and see if we can figure something out so we can not have this situation happen again, okay?
Okay, thank you.
All right, you're welcome. Hey Clarissa, how are you?
I'm good, how are you?
I'm good. I just have a concern. We have a patient up on our floor who come in through the ED with a COPD exacerbation and admitted him to the floor. Everything was good. He was here for about 3 days, set to go home, and the nurse resident went in and realized that there was a possible DVT. They had no prophylaxis orders in, no TED hose, nothing in place. And they came to me as a charge nurse that they were concerned that there should have been something done to prevent this so that this, they wouldn't have formed the DVT. Because as I said, had we sent them home like we had originally planned to do, or they didn't express their pain, this could have been a serious event and they would have ended up back in the hospital and it would have fallen on us. So I looked and I don't think there's any policy. I typically, we see it done just, already they go ahead and send them up with TED hose, or they put them on when they get to the floor, they're given Lovenox, one of the, options, but nothing was done here and there's no policy saying that they have to do that. So I don't know what your suggestions are, but I think that we need to get a policy or some sort of protocol in place so that this doesn't happen again.
Yes, we need to get a policy. We need to get, did you say it was a resident that
Yes.
caught it? We need to get the resident, the admitting ER doctor, and the nurses that took care of them. And we need to get a meeting and put a policy in place because this is a serious event and would fall back on the hospital.
Right.
I'm glad he caught it, but we do need something in writing and not just per doctor how they want to do it, but
Right.
something in stone.
I agree. Okay, so I'll get my nurses and residents together and we'll come down and we can sit down and see if they have any suggestions or what we want to do.
That would be great.
All right.
Thank you.
Thank you.
Thanks guys for coming in on your day off. We needed this meeting because we had a potential patient that could have been detrimental. The first year resident did catch his signs and symptoms of a DVT, but we're meeting today to put a policy in place because he should have put on prophylaxis treatment. So I'm here to get your kind of opinions, what you feel about the policy, what should be implemented, and we can kind of go from there if you want to start and kind of say who you are and what you feel should be in the policy.
Okay, I'm Casey. I'm the nurse that brought the patient up to the floor from the ED. I feel that from the ED standpoint, if we do put a policy in place, the nurse could be the last factor before they leave the ED to make sure that admitting standing order is in the computer system.
I'm Tiffany. I'm the floor nurse who took care of this patient. I feel one good step to implement into the policy would be when the ED nurse brings them up to the floor, we could double check through the MAR system and make sure that policy is it's ordered and the standing order is already set for like a heparin or anticoagulant. Make sure they have SCDs and TEDOs on and whatnot at that time.
I'm Bethany. I'm the senior resident over Julia here. I was surprised that this hospital did not have a protocol set in place because I've been in other facilities where if a patient's at a high risk for developing a DVT, we don't need a doctor's order to do so. It's a standing nursing protocol they can implement to help prevent blood clots.
I'm Mallory. I'm the charge nurse up on the floor. I think that we need to just have kind of like a checklist that the nurses run through. I understand that, the doctor should put those orders in, but as nurses and as my nurses to cover them, I want them to have a checklist in the chart that maybe they can just run through and say, yes, they do have Lovenox ordered or they don't, and if they don't, then they need to put in a request or they need to order that to the doctor and see why it's not ordered or go ahead and get the okay to do something like that.
I'm Liz. I'm one of the ED physicians. I was actually there. I treated her when she was down there. Because there's no policy procedure put in place, it's at my discretion whether I put him on a blood thinner or whatever. And at that time, she was not showing any signs of that. And after that, she was going to go home the next day. So that is why I did not put her on any kind of blood.
My name is Julia. I'm a first year resident, and I actually came into the patient's room when she was complaining of leg pain and discovered that there was a DVT, and we got the ultrasound ordered, and that was found. I think that with this patient, it was hard to see it coming. She came in for COPD. She's kind of a frequent flyer. We thought she'd go right back home, but she ended up staying due to infection. So I think that this should be something that's followed up on daily by the nurses rather than putting it on the first person that sees them is responsible for knowing that they're going to be bedridden for 4 days. So I think this protocol is a really good idea. I think it needs to be made available in the charge where nurses and physicians can both check that it's completed. Make sure that the responsibility is understood, because it could have been a very bad situation if she would have went home that same day and then had a stroke or a pulmonary embolism. So I really like this idea.
Okay, those are all really good points. I'm going to get a hold of our sister hospitals, do a little research, and kind of see what would be the best policy for our facility, because I do agree that just putting it on one person responsible after they're out of your hands, we need something in there that's being checked every day and status changes. So I'm going to get a hold of them, do some research, and then we'll have a meeting next week and then get this policy in place, okay?
Okay,
Thank you.
thank you.
Thanks guys for coming back. I did get a hold of our sister hospitals and did some research. I wrote up this policy and just kind of let me know if you agree with it. The main thing is when a patient does come into the ED, we're automatically going to do through their history and physical, we're going to do risk factors. If they have one or more, we're going to implement prophylaxis. And I'm going to give you some examples because I sent it out in an email to everybody in the hospital. So like one of them is if they're over 40. So for our lady, she was 65, so she should have automatically been put on TEDHOs, and she should have been checked for platelets and to see if she needs heparin or Lovenox. And another one would be if she's had previous history of DVTs, or she's had chemotherapy, or if she's obese, or some kind of heart failure. So the higher the number gets, the more serious you need to be on top of it. So that part is going to be on the ED nurses and the physician to make sure that that history gets done and gets put into the patient chart. So then when they do get admitted to the floor, it'll be in that chart, you'll be able to read it, and then it's the nurse's job on the floor to make sure that heparin or Lovenox was ordered within 24 hours. And they need to make sure that they have TEDHOs when they're on the floor and any other prophylaxis treatment that's mentioned in this policy. Do you guys have any questions or concerns concerns about the policy?
Can I just add a comment?
Yep.
Well, when they get up to the floor, that's when the floor is going to do the actual admission history. So I think if the ED catches a high risk, they should pass it on in their SBAR report. But then once the nurse actually does the admission history, they can further ask the patient if they're a smoker or this and that, other reasons why they make them high risk.
Okay.
I don't think it should just fall on the ED nurse because they don't have the time to do a full admission history. I think once they get on the floor and they do the full admission history, that's when you'll be able to put in the actual risk level that they are to develop a DVT.
I agree. As the ED nurse, I think that she is right. We don't have the time to do the whole history, so we could, if we see someone that's high risk, we could definitely pass that along in the report to the other nurses on the floor.
Okay, but you still want ED to be responsible for putting this risk assessment in the chart to be sent up, or do you want the chart to be added to the chart on the floor?
Well, I think like with this patient, the ED nurse would have missed it completely
Right.
because that's not why they were admitted. But once on the floor and done a more thorough admission history, they would have seen that they were over 40, COPD, she's a smoker. That adds to all the risk of why they would have developed the DVT.
Okay, so what would be considered high risk for you if they came into the ED? Like previous DVTs? Is there anything else that would red flag to have an SBAR to go ahead and-
Immobile.
Immobile?
Stroke, history of strokes.
Okay. All right, so I'll change this and then put ED. If those three are high flag, they need to be SBAR'd and inserted into the chart. And then at the floor, it'll be on the nurses on the floor to actually do the further assessment of smoking, chemotherapy, age, that kind of thing. And then we'll just have to have our good communication skills. So I'll get this fixed out and then I'll send it out, and we should avoid this problem in the future.
Is there going to be a time frame for this policy to be implemented so that our staff, all the staff is on the same page?
I'm thinking about holding a service at the first of the month, so that'll be next week. We'll have an in-service paid, we'll have food and stuff to bring everybody in to update them on the policy that's implemented so everyone's on the same page. And then whoever does not come to the staff meeting, we'll have to individually meet with them on the floor, and you'll be a part of that for your team and each charge nurse of each floor. We'll make sure that each nurse is up to date of the new policy, and then every 6 months, we'll re-update this policy as the other ones.
Can I have one more clarification? It is, so we're saying it's the expectation that every patient will get this risk assessment between the
Yes.
ED and the admission to the floor?
Yeah, ED would only be expectation if they are high risk with previous DVT, stroke, heart problems, immobile, and then a further assessment will be done on each individual floor that they're admitted. But this will be in their chart, this risk factor that, like the Braden scale, it'll be one of those in the chart that you can go through and check mark when you're doing your history.
I think that sounds great.
Okay, thank you guys.
Thank you.
Thank you.